My presentation is about improving outcome in renal transplantation. Renal transplantation represents the best option for patients with end-stage kidney disease when it's done properly. And even patients who received incompatible transplant have by far much better outcome than those in the waiting list for transplantation. And although transplantation started as early as the early 40s with successful renal transplantation using just azacitidine and steroids, and it's much improved with introduction of cyclosporin and tacrolimus and mycophenolic acid derivatives. With living donor expanded criteria, we are now transplanting a huge number of kidneys all over the world. However, there is still a great chance for improvement aspects. We can improve donor and community education, patient selection, stratification, induction therapy, maintenance, early detection of rejection. We can improve the long-term complication and survival of the graft. This is what I'm going to speak today. It's now well known that survival of transplant patient is far from survival of patient on dialysis, and it's almost close to normal population. And survival benefit for transplant patient occur with early ages of renal transplant patients. Those who are age 20 benefit much more than those of 50. And also, those at age 50 also benefit a lot and survive much more than those transplanted at later. And if we compare complication between dialysis patient and transplant patient, cardiac event, heart failure, ischemic heart, MI, and inhospitalization is by far less in those who are transplanted. And the benefit of transplantation regarding physical functioning, bodily pain, mental health, emotional and social functioning, the vitality, the general health is by far much better in transplant patients than those on dialysis. And to expand donor criteria, we need to inform that donors are not at great risk of donation. This is a very important study showing that with liver kidney donation, the life expectancy is reduced by 0.5 to 1 year in most donors. And the development of end-stage kidney disease in donors may not be the only measure of risk, as most of the predicted loss of life predate end-stage kidney disease. So half a year or 1 year does not represent a great risk for the donors. Also, we need to improve patient selection and stratification. And we should remember that patient recruitment is usually done by the physician. Few patients usually seek transplant, and patient usually is not informed of transplant possibility in their units. Patients are depressed, there is lack of knowledge of treating doctor and nurses, there is fear of expenses, and in Ain Shams University Hospital, we do it for free for most of our patients, if not for all of our patients. Patients are not informed that they have available donors in the family. There are other factors, and we should follow this flow chart to encourage patients and families to go into liver-related transplantation. We should also risk stratify the immune status of every patient to improve the outcome. And we have now clinical risk stratification measures to select the best patient and to avoid the major complication, and thus we can improve the outcome in renal transplantation. It depends on age, on performance score, in presence of other comorbidity, and we can know now those at low risk, those with average risk, and those with above average risk, so we can be prepared for them and we can do the best immune modification to get the best benefit of renal transplantation. In most transplant patients, we do the ordinary cross-match, but we have to consider the whole, not only the whole engine mismatch, but also the ablet mismatch sum and the single molecule ablet mismatch, because knowing this before transplantation will improve the outcome in patients going into renal transplantation. And outcome of transplantation with these HLA-DR and DQ mismatches are worse than those without mismatches. Another important issue in improving the outcome is patient compliance. We should test for patient compliance because the major cause of loss of graft is patient non-compliance. And we have some impact to know or to detect those that will not comply after transplantation and to avoid transplanting them. And this will improve the outcome and will save the donor pool. So patients who spend long time after transplantation tend to be non-compliant. Patients who have no access of care, no provider-patient communication, patient transition from young to adult transplant program may have this issue, and patients who are adolescents or getting married, and patients past non-adherence or loss of graft before, or those with low health literacy, we should be very cautious before transplanting them, and we have to educate them and the families about the risk of non-compliance before starting the process of transplantation. Having said that, let us talk about the medication selection to improve the outcome. We have induction and maintenance in transplant patients. So induction, there are many clinical trials showing that induction agents either prevent or delay the development of acute rejection with good impact on the long-term outcome in transplant patients. And as of 2008, 13 years ago now, induction agents were administered in almost 82% of kidney recipients. There is now evidence that induction immunosuppression improves long-term graft and patient outcome in organ transplantation. And this is an analysis of United States Network of Organ Sharing Registry data showing that for most patients now, almost 80% are receiving T-cell depleting induction agents. Few patients now are receiving interleukin-2 receptor agonist, and few patients have no induction. Those are with low risk. And using low-dose ATG, total dose 2.25 milligram per kg versus standard dose of 3.75 milligram per kg have shown to improve outcome with minimization of the side effect of ATG with the same impact on graft survival and prevention of acute rejection. And this also helped in patients who have early steroid withdrawal. And this recent study have shown that using low-dose rituximab with thymoglobulin induction can improve outcome in patients who are planned for steroid-free protocols. And this might be a future in induction to improve the outcome and to prevent complication of multiple medications, as well as to reduce rejection. The selection of maintenance immunosuppression is very important to improve outcome in renal transplantation. As I mentioned before, it started with azathioprine and steroid in the early 50s with 50% loss of graft and 50% acute rejection. And with introduction of cyclosporin in the late 60s and early 70s, rejection was much reduced and there is improvement in outcome. With tacrolimus and MMF and mycophenolic acid, there are now extended benefit with very good outcome. Rejection reduced to almost 15%, and nowadays, after using induction therapy with ATG, it's less than 10%. So maintenance or selection of maintenance immunotherapy is very important to improve the long-term outcome. And as early as the 80s with cyclosporin, the outcome is very much improved nowadays regarding survival. And the most commonly used protocol is tacrolimus MMF steroid, then TAC MMF, then TAC steroid, and others. However, there is a way to improve outcome by either withdraw or avoid steroids, minimize or avoid CNI using combination of CNI and mTOR, and this may have impact on improvement of outcome of renal transplantation, as I will discuss. The US data showed that 70% of patients with renal transplantation are using tacrolimus twice daily, while 67% are using steroid. MMF is used in 55%, mycophenolic acid 14%, cyclosporin 14%, sirolimus 11%, and azathioprine 7, tacrolimus once daily, or platacept everolimus is very few patients are using them. One of the very important issue in transplantation is to avoid complication of the medications. And we know steroid is associated with the most common and most feared complication in transplantation: diabetes, hypertension, osteoporosis, avascular necrosis of the neck of femur, dyslipidemia, PTLDs, and other. So there were protocols to early or late steroid withdrawal. But we should know that the timing of steroid withdrawal is very important. It's important to be less than 3 months. After 3 months, it's extremely dangerous. And also, when we withdraw steroid or when we plan to withdraw steroid, we have to be assured of what other medication are used. The best is when we use CNI and MPA. And also, for most patients who need or who will go into steroid withdrawal, induction therapy with thymoglobulin is very important. And steroid withdrawal was shown to be most successful when patients are using tacrolimus MMF combination, and less and very dangerous when the patient are using azathioprine and cyclosporine. And steroid withdrawal was safe, even in high-risk patients. This is a systemic review and the meta-analysis, including hundreds of patients, showing that early planned steroid withdrawal can be used even in patients with high risk in transplantation. What about CNI minimization and withdrawal? CNI is also associated with complications like development of diabetes, dyslipidemia, hypertension, and so there was the Elite Symphony trial in 2007, and there was the Caesar study to avoid CNI completely. The Elite Symphony was minimization study, one of the major milestone in transplantation, and it showed that using low dose tacrolimus with MMF and steroid was associated with the best outcome ever in transplant, and associated with less biopsy proven acute rejection, and with the best graft survival. And after Symphony study, most transplant patients are now using this medication, MMF, tacrolimus steroids. mTOR conversion to avoid CNI is usually associated with increased incidence of rejection, but it should be considered when GFR is only above 40 millimeter per minute, so you cannot do it in patients with bad kidney function. And patients should not have urinary proteinuria, because this will be exaggerated using mTOR. And also, we should check the patient for the incidence of acute rejection that might reach up to 25% with the use of mTOR conversion. Recently, in Transform study, it was shown that the use of mTOR inhibitor, everolimus, with CNI, either tacrolimus or cyclosporine, was non-inferior to using MPA with a calcium inhibitor. And the outcome of renal transplantation is almost the same, and the GFR is almost the same in the two groups, those with low-dose everolimus and low-dose CNI versus those with CNI, full dose, and MPA with less CMV infection. And this might be an evolution of how to select maintenance immune suppression in transplant patients. And in this open label randomized trial, it shows that everolimus with tacrolimus or cyclosporine is comparable to standard immunosuppressive kidney with good graft survival and same rejection rate, almost same rejection rate. But notice that there is less CMV infection and less picky virus infection. Having reporting that, still, this is a January 2020 American Journal of Transplantation showing that the OPTN SRTR 2018 annual data report of kidney transplantation showing again the major combination therapy is TAC MMF steroid in most patients, followed by TAC MMF only in almost 30% of patients, and others are of limited use. A relatively recent, it is not recent, it's introduced since 2005, and it was studied in the benefit study in 2010 with very good result, the belatacept, which is a co-stimulatory blockade. In order for T cell to be activated and to clone or produce antibody or become a T helper cell, it needs to be activated by the antigen presenting cell. And this needs two signals. First, presentation of the antigen, and then we need second signal that can occur on CD80, CD25, on the complement system, in CD40, and many other pathways. And we also have the signal 3, which includes cytokine stimulation. And so these two signals can be either, we can block each or either signal to prevent T cell from proliferation. And belatacept work in the co-stimulatory pathway in CD28. And so it's not only, we are not only blocking signal 1, but we can also block signal 2 and prevent antigen presenting cell to present the antigen to the T cell. It was examined in the benefit and benefit extended studies and showed very good, almost comparable result to cyclosporin with better GFR because it has no cyclosporin nephrotoxicity. And also there is less incidence of post-transplant diabetes. However, this medication is not available in most of the Middle East. It's not available in Egypt. And it has also some drawbacks and some precautions. That's not the place or the time to discuss it. We also need to improve outcomes through early detection of rejection, because it is the most feared complication of transplantation is rejection, especially if it occurs early on in the course of transplantation. And what we have learned about how to prevent and treat antibody is still very few information. Even using pathology to diagnose antibody-mediated rejection in the most excellent centers have shown that in all antibody-mediated rejection or mixed, out of 46 patients who have this antibody-mediated rejection, the pathology is not conclusive. In many patients, the features only notice in text is 19, and the statement of suspicion in the final diagnosis is 9, and the clear statement in the final diagnosis is 18 out of 46. Also, depending on C4D, positive or negative, we have the same result. So there is no enough tools to diagnose early rejection or to be sure of early rejection. And that's why molecular microscope was introduced recently, which can diagnose and can use predefined measurement of T cell mediated rejection, of antibody mediated rejection, of atrophy scarring score, of prognostic score and progression to failure, acute kidney injury, and also probability of non-adherence. This molecular microscope is not available in most countries, but there are a lot of publications starting from 2012, and they have published the very important role of molecular microscope to approach and to identify early rejection, the type of rejection, and as I've mentioned, many other aspects of post-transplant complication. One other important issue, when the patient has subtle inflammation, we cannot diagnose this patient because kidney transplantation after a few years, the patient seems to have stable kidney function. However, there might be a biomarker or there might be drug targets to determine if he's over immune suppressed or under immune suppressed that will result after few other years of either rejection, alloimmune damage, or non-immune chronic damage by IFTA and CNI-induced toxicity. So we need tools to diagnose patient at this stage to prevent the worst outcome and to detect which patient will have normal histology throughout long period of time. There are many non-invasive biomarkers that have been suggested to detect acute rejection in patients with kidney transplantation. These include the 3 gene signature in urine, the key sort, the CXL9 and 10, and the donor-derived circulating DNA. This is a very important tool that's now under investigation and have shown that if we detect donor-derived cell-free DNA in the recipient, this might show that there are tendency for rejection in this patient, and we have to interfere as early as possible. Also, microRNAs, it's over-studied to detect which microRNAs that can detect early rejection, and we have now some microRNA with area under the curve of 70%, which means good specificity and sensitivity to detect early rejection. Treatment of rejection still the same since long time: plasma exchange, ATG, rituximab, IVIG with different combination according to different scenarios of the patient. However, there are several studies to detect and prevent late antibody-mediated rejection, which seems very troublesome because we have no standard treatment for chronic active antibody-mediated rejection, especially if it occurs late. And these trials is now introduced to detect if this agent can deviate the late acute antibody rejection or the late chronic active antibody rejection. And this includes the use of costimulatory blockade by belatacept, the anti-PLIS monoclonal antibody, the anti-interleukin-6 tocilizumab, we know tocilizumab now, and calazekizumab, which is a very promising molecule. Bortezomib, also we know the proteasome inhibitor, the CD38 monoclonal antibody, the daratumumab, also the C1-INH and anti-C1 monoclonal antibody, which is targeting the membrane filtration, anti-C5, eculizumab, and also the IDs and the intravenous immunoglobulin. These are now tried to in the treatment of chronic active antibody rejection and late acute antibody-mediated rejection to improve outcome in kidney transplantation. And there are several studies, mainly in the eculizumab, the IVIG, the bortezomib, and also the calazekizumab, which is showing a very good outcome. So in the future, we may have tools to treat chronic antibody-mediated rejection, especially if occur late after kidney transplantation. And finally, if we can induce tolerance, it will improve the outcome marvelously. And there are many ways of inducing tolerance. One of them in this Mercury study, this group are studying chimerism to prevent, to induce tolerance. They induced mixed hemobiotic chimerism and donor-specific immune tolerance. So we can use, we can prevent the use of anti-rejection medication and the immune suppressive medication. One other way is the use of the exosome, and also there is a long-term allograft survival by using chimerism induced by exosomes. Again, this is not the place to discuss this in details, but finally, I have to say that we have still a large prospective vision to how to prevent and how to improve outcome. And this should start by the recruiting of the patient, the education of the patient and the family and the community, the patient selection and stratification, the use of proper induction and maintenance, early detection of rejection and anticipation of any change in kidney function, induction of tolerance, and finally, thank you very much for your listening. And this is time for questions.